Dr. Sourabh Kulkarni. I am orthopedic consultant and a joint replacement surgeon. I am director at Robotic Joint Replacement Center, which is there in Shriyash Orthopedic Trauma and Joint Replacement Center, functioning in Navi Mumbai. Actually, I am doing joint replacement since last 15 years. So the first knee replacement was done in 1968. It is 55 years down the line. We have improved a lot in terms of implants. We have changed the design. We have changed the patella tracking. We have changed the materials. We have come up with cobalt chromium. We have come up with titanium coating on a cobalt chromium. Also, we have done multiple changes in cementing technique also. But what next? What about the human hand error? What about the human eye error? Can a human eye distinguish between 4 degrees and 5 degrees of angulation? What about the human emotions that are played while doing the surgery? So I thought about it, and the answer to that was the improvement will be if a robot or a machine which is very precise in accuracy will give me some feedback regarding the surgery, and which will have a good steady hand to cut the surfaces. So that is why I joined robotic lineup, and I'm very happy that I have transformed myself into a robotic joint replacement surgeon, and I'm very happy about it. See, I am a surgeon who has been initially trained into manual conventional knee replacement. So all my reflexes, all my knee replacement teaching was according to the conventional. But in robotics, what we do is before starting any cutting, we do gap balancing, we do all those calculations. So understanding the gap balancing values on screen, interpreting a range of motion graphs which were showed in the surgery, they were initial challenges. I had to adapt to all those situations. So it is like understanding your partner in a marriage. It is difficult, but if you understand your partner to the best, the life is beautiful. Similarly, if you know your robot well, then your results are amazing. And the second biggest issue in robotics is the upfront cost of the system. Initially, the cost is significantly high. I also thought whether should I invest so much, but when I understood the cost of having revision knee replacement, cost of unhappy patient, then I realized this is worth the spend, and that was not a bigger problem to me. And thirdly, there were few incidences where patients were not ready to accept the robotic surgery. They were saying, doctor, can we trust the robot? But definitely you should assure them that it is not the robot which will do the surgery. It is a surgeon which will control the robot, and robot will do exactly what a surgeon wants it to do. I think these were the initial challenges that I faced. So the similar question I asked when I bought a robotic system, to whom should I give it, to whom should I not? But that one person is going to get his knee replacement once in a lifetime. So isn't he deserving the best one? So according to me, each and every patient who is undergoing joint replacement deserves to have the more accuracy. So I think every candidate is a candidate for robotic knee replacement. But suppose if you are asking me a specific question that who are the candidates for robotic knee replacement, then exaggerated femoral bow patients, patients with malunited femoral fractures, patients with malunited tibial fractures, extreme torsion cases, extreme deformities, these are the candidates for robotic. So as you asked me this question, I definitely can quote one of my patients. He was an 86-year-old man with bilateral severe osteoarthritis since last 30 years, I can say. And patient was having femoral varus, that is the in-bowing deformity